Dr. Muñoz is a professor in the Department of Surgical Specialties, Biochemistry and Immunology, School of Medicine, University of Málaga, Málaga, Spain. Since 2000, Dr. Muñoz has been actively researching patient blood management strategies with emphasis on perioperative anemia management, bleeding control, and cell salvage. I'm sure you've seen his name on a lot of papers. He has over 200 publications in this field, including original research, reviews, and consensus statements and book chapters. So Dr. Manuel Muñoz, intravenous iron therapy, practical points for the clinician. The floor is yours. We have much to learn from you.
First of all, welcome everyone to this interesting meeting. And thank you very much to the organization for inviting me to participate. Well, the topic today is intravenous iron therapy, a practical point for clinicians. I will not give a technical talk, but I will try to integrate this within the treatment of anemia, and I will explain you why. The main problem is can be reflected in this paper that is almost 10 years ago. Is over 16,000 consecutive patients undergoing cardiac surgery and at a single center. And they found that compared to patients that have not massive bleeding or red blood transfusion, those who has major bleeding or transfusion have 3 times the risk for perioperative mortality. And this risk increases up to 9-fold when both conditions are present. They have a major blood loss and red cell transfusion. But on top of this, if the patient presents with the preoperative anemia, the risk is further increased. So the conclusion of the author was that major bleeding is per se a risk factor for perioperative mortality, which is potentiated by red blood cell transfusion and to a lesser extent by anemia. But one can think, well, it's only a little bit more. But if you go to a recent meta-analysis of the 24 studies, including over 1 million patients, they found that the prevalence of anemia was around 39%, and compared to the non-anemic patients, those who present with the preoperative anemia have a higher risk of acute lung injury, stroke, postoperative infection, postoperative mortality, and 5-fold risk of transfusion. So it is important. And preoperative anemia is frequent, and it led to a worse outcome in the patient. So the clinical problem we have is that the preoperative anemia, perioperative blood loss, and allogeneic blood transfusion work together to produce a poor clinical outcome in the patient. And what is the solution we have for this problem? Well, the solution we are implementing now, mostly in Europe, it's patient blood management. Like with this, the previous speaker, the Dr. Speed, have clearly defined as a step in the way to bloodless medicine. And well, all you know that patient blood management is based on 3 pillars. When it's a preoperative stimulation of erythropoiesis, reduction of blood loss, and harness the anemia tolerance. That will allow us to reduce the transfusion rate, and in most of the cases to avoid transfusion completely. But it is important to note that avoiding transfusion is not the target of patient blood management. The target of patient blood management is to improve the clinical outcomes. And well, we know that by reducing transfusion, we will improve the clinical outcome. And it's something that we will get when we establish the whole process. The most difficult part of the implementation of patient blood management is the management of perioperative anemia. And we needed to treat it with iron, vitamin B12, folate, and EPOs. But before that, we need to do a right diagnosis and do it timely. So, a few years ago, we joined a group of, let's say, experts to develop a consensus statement on how to manage perioperative anemia and an iron deficiency. And we produced an algorithm that we believe that can facilitate the management of patients. The algorithm starts when the patient is listed for surgery, and then we have to ask a simple question: do the transfusion risk is higher than 10%, or the estimated blood loss higher than 500 ml? If the response is not, then we can understand the preoperative evaluation and proceed to surgery. But if the response is yes, then we have to understand laboratory work up to identify the presence of anemia and to classify it in order to give the appropriate treatment. So what we will need a fluid blood count, reticulocyte, iron parameters, vitamin B12 and folate, an-inflammatory marker like C-reactive protein and creatinine, or estimated glomerular filtration rate. With this parameter, we can classify most of the anemia in the surgical patients. Well, when we receive the results, we can see, well, the preoperative hemoglobin is below 130 for both men and women. No. Is there any hematinic deficiency? No, then we can proceed to surgery. If yes, and especially it is the iron deficiency, we have to prescribe a supplement because there has been described an association between iron deficiency and a poor outcome in cardiac surgery and in intensive care patients. When we prescribe the supplement, we can proceed to surgery. But if the patient have a hemoglobin level of less than 130, then we have to decide we are facing an elective surgery, and then we have to classify the anemia and start with the treatment. And this is the way we do it. We have an anemic patient. The first thing we look at is to the iron test. If there is an alteration of the iron test, we can define an iron deficiency anemia, an anemia of chronic disease with iron deficiency, or an anemia of chronic inflammation. If the iron tests are normal, then we look to the vitamin B12 and folate levels. If they are low, we are facing megaloblastic anemia. If they are normal, there must be another kind of anemia, including renal, endocrine, drug, malignancy. And finally, in some patient will arrive to the diagnosis of is an anemia of unknown cause, because we don't have any more laboratory tests to classify it. So this is this algorithm working? We tried this in a retrospective series of over 3,000 patients from 5 Spanish centers undergoing 6 frequent surgical interventions. And what we found is that the prevalence of anemia was 36%, using and hemoglobin cutoff of 30 grams per deciliter for both genders. This is important. And regarding the hematinic status, we found that around 70% of anemic patients presented with absolute or functional iron deficiency, 40% of non-anemic patients presented with absolute or functional iron deficiency, and 40% of all patients present with low iron store, as defined by the ferritin below 100 and a transferrin saturation about 20. That means that the patient have not iron deficiency, but they have not enough iron in the store to recover from the bleeding caused by the surgery. And all these patients can benefit for iron therapy. In contrast, the folate vitamin B12 deficiency was much lower, less than 10%, and curiously, it was more frequent in non-anemic patients than in anemic patients. So, if we are going to treat iron deficiency, the first option is to use oral iron salt. They are cheap, easy to provide, but they have a lot of gastrointestinal side effects that can compromise the tolerance and the adherence to the treatment. And finally, the efficacy, especially if patients have some inflammation. So we only recommended this therapy for mild iron deficiency anemia, for non-anemic iron deficiency or low iron store, provided that we have between 6 and 8 weeks preoperative leave to treat the patient. And when we do so, we recommend daily doses of 40 to 50 milligrams of elemental iron per day, or moderate doses of 80 to 100 milligrams every other day. This way, we can increase the fractional absorption without compromising the efficacy and the safety. On the contrary, the administration of oral iron salt is not recommended for the treatment of postoperative anemia, because the high level of oxygen after surgery will avoid the intestinal absorption of the iron, and therefore IV iron is recommended in this patient. The other option is IV iron formulation, and that modern iron formulation are safe, and the European Medicine Agencies stated a few years ago that there is not different in the safety profile between all marketed IV iron formulation, but still there is an infusion reaction that can occur in approximately 1 in 200 patients. The anaphylaxis risk is very, very low, but still we need the venipuncture to administrate the compound, and obviously they are more costly than oral iron salts. However, IV iron has emerged as a safe an effective alternative to oral iron for treating iron deficiency anemia, especially in case of intolerance or contraindication to oral iron. And of course, it is refractoriness to oral iron. In patients with inflammation, because IV iron can bypass the hepcidin blockade. When the patient have moderate to severe anemia, because we will provide enough iron to correct it. in patients with ongoing blood loss, because oral iron will not keep with the need of iron. When we use erythropoiesis stimulating agent, it has been demonstrated that the response to exogenous EPO is better when we give IV iron than when we oral iron. In patients with moderate to high surgical blood loss, and when we have a short time to major surgery, that means when we have less than 4 weeks to surgery, we need to use IV iron to treat iron deficiency. And this is it's also important that even when we have a short time, even if we don't have 3 weeks or 2 weeks, we have to always classify it and treat the anemia. I will show you some data later. Nevertheless, there's some important issues regarding IV iron that we have to keep in mind. The first thing is that the IV iron is not a magic bullet. You cannot expect that you can rise the hemoglobin a few days after the administration of IV iron. Within a few days, you will feel an improvement in well-being. In 1-2 weeks, we will see an increase in reticulocyte count and subsequently a hemoglobin increase. And in 1 month, we will see the normalization of ferritin and hemoglobin, if we are lucky. Not always is that the case. So we don't have to think that because we are giving IV, it will work in a few days. It will take several weeks to get the full response. And this has been very nicely proved in this study by NIF, published in Blood Transfusion 2 years ago. They treat 400 anemic surgical patients with ferric carboxymaltose at doses of between 500 or over 1,000, and they found that the maximum response to IV iron in terms of hemoglobin increase was seen between 26 and 30 days after the IV iron administration. So again, it's a time frame of 4 weeks, 1 month is the ideal for getting the appropriate response. Also, we have to take into account the effect of anemia severity. In this study of 84 anemic patients with iron deficiency or functional iron deficiency, we administered iron sucrose doses of 800 to 1200 milligram over 4 to 6 weeks preoperatively. And we will see that there was a nice response according to the baseline hemoglobin. The lowest the baseline hemoglobin, the highest the response to IV iron. And this was particularly obvious for women scheduled for hysterectomy, because they have let's say the more pure iron deficiency anemia with low degrees of inflammation. So some of these women increase between 3 and 5 grams per deciliter their hemoglobin concentration in 4-6 weeks. The response was a bit less in the arthroplastic group, because they have some kind of component of inflammation, and obviously was less evident when we treat colorectal cancer, because of the combination of iron deficiency, inflammation, and blood loss. Later on, ferric carboxymaltose was introduced in Spain, and we repeat the same study, but using ferric carboxymaltose, and we observed that the final response, the hemoglobin increment, was similar at the response rate and the anemia correction rate was similar between the two compounds. The only difference we saw was the allogeneic blood transfusion was lower in the ferric maltose group, but it was accounted by the colon cancer patient. This patient received more IV iron than in the previous series, and they were more. They have more laparoscopic intervention than in the previous series. But probably the most interesting thing is that we are right to the same hemoglobin increase, but with much low, with fewer sessions. So we need 5 sessions, a minimum of 5 sessions to treat the patient with iron sucrose, and only 2 sessions to treat the patient with ferric maltose. That facilitates the treatment a lot, and also compensate the increased acquisition cost of ferric maltose. So then, if we arrive to the same point, what is different to use the iron sucrose or ferric maltose or any other high dose iron? Well, this is the normal way that iron is moving in our body. We have iron in the store, and every single day, 25 milligrams are needed to replace the red blood cells by the bone marrow. This 25 milligrams come out from the store through the ferroportin. This is the only known iron exporter we have in the human body, and with this amount of iron, we got a transferrin saturation or around 30-35%. When we have inflammation, hepcidin provokes internalization and destruction of ferroportin, so the flow of iron from the macrophage to the transferrin is reduced to around 50 milligrams per day. That means that we found a transferrin saturation below 20. If we give several doses of IV iron with a compound that allows for low dose infusion, we will provoke an iron overload inside the macrophage. And the macrophage will respond, increasing the expression of ferroportin, and this will counterbalance the inhibition of provoked by hepcidin, so we can increase the amount of iron that is being released to the circulation, and we can restore the transferrin saturation. Interestingly, we can get the same effect when we do have a high dose compound, and when we are able to administer 1,000 milligrams or more. So we can get the same effect, but just in one session, and it again facilitates a lot of treatment. So which iron formulation we can use? Well, I don't know how it's the situation in your area, but for instance, in Spain, you cannot decide which type of formulation you can use. It's just the one that had been acquired by the hospital. But if iron sucrose was the first one we used, and it's even today it's widely used. You can give it at low doses, only 200 milligrams per session, with a maximum of 300 milligrams per week. So you require multiple infusions to give to the patient 1 gram. And we have to take care about the alkaline pH of this preparation, and so we have to be very careful not to produce extravasation of the compound, because it will be very painful for the patient. Later, we have a ferric maltose. It can give a high dose, 20 milligrams per kilogram, with a maximum of 1,000 milligrams per session in Europe, 700 750 milligrams in US. He can give this can be given over 15 minutes. This compound have a very low concentration of free iron, so the infusion reactions are less frequent than with iron sucrose. But ferric maltose have the problem of hypophosphatemia that can be presented in up to 50–70% of patients. Not always are clinically relevant, but it is a problem. But we don't we have to face, and we don't know exactly how to manage. More recently, there is a new compound that is there is maltose that also can be given a high dose, 20 milligrams per kilogram, with a maximum of 2,000 milligrams per session. That means that we can satisfy the need of iron from the majority of our patients. It can be given between 15 and 30 minutes. Again, this formulation has a low free iron, and we are getting growing experience on the use of this formulation in surgical patients. Last but not least, that is a relatively old molecule, this low molecular weight iron dextran, that also can be given a high dosage, 20 milligrams per kilogram. There is not top dose. You can give the total iron. You can cover the total iron deficiency in one session. The problem is that you need between 4 and 6 hours to give the total iron, to make a total iron infusion. But the advantage is that it's a very low price. It's 1/5 the price of a ferric maltose or ferric maltose. So we can balance the two things. Just talking about the total iron infusion with Michael Auerbach. This is an oncohematologist from the US that probably most of you know. We were discussing if we really need to give such a big amount of iron to the patient in one sitting. And I convinced him, and he tried to do a smaller dose of just 1 gram, but in a shorter time, 1 hour. So these are the data from almost 400 consecutive anemic patients, mostly with heavy uterine bleeding or gastrointestinal bleeding. This patient received 570 infusion of 1 gram low molecular weight iron dextran on a median time of 63 minutes. Only 10 patients were pre-medicated with prednisolone. The mean hemoglobin increase was 1.1 gram per deciliter at 4 weeks. Of those patients, 55% have an hemoglobin increase equal or higher than 1 gram, and 26% equal or higher to 2 grams per deciliter. There were very few adverse events, only 6.5%, more frequently among patients that have allergy to some medicaments, and only 7 of them need to be treated with methylprednisolone, and 2 of them were treated with acetaminophen. There were no severe adverse side effects, though the author believed that, well, because the low incidence of this kind of adverse event, they will need at least to include 3,000 patients to find one. So the conclusion is a bit limited with that. But altogether, what said, this is a compound that can effectively and safely treat anemia in the preoperative period, and with the advantage that we can the acquisition cost is much lower than the other ones, and I think that a 1 hour infusion time is something that can be assumed by any hospital. So when we have classified anemia and started treatment, we have to think about to postpone surgery until the patient is no longer anemic, or at least we get a reasonable hemoglobin level to according to the intervention. If we are talking about non-elective surgery, we still can classify the anemia and start the treatment, and then proceed to surgery. The treatment can be completed after surgery while the patient is in the hospital. This is our data on over 500 anemic women with sustaining hip fracture. And you can see that compared to the control, those receiving IV iron or IV iron placebo show a lower transfusion rate. But we were not completely satisfied with this result, and then we reanalyzed the data according to baseline hemoglobin, and then we found that really the group that benefit, that significantly benefit from this treatment strategy, were the women with hemoglobin between 12 and 13, that according to who were non-anemic, but according to the most recent guideline, they are. So this is one more reason to use the same hemoglobin cutoff for defining anemia in the surgical setting. No women discrimination in this area, and a cutoff of 13 for both genders. Most probably we can improve further this result adding tranexamic acid, and in this regard there is a recent trial that has been finished, the HIFI trial, comparing the use of tranexamic acid with IV iron and IV iron placebo, either alone or as a combined treatment. And the patients that receive IV iron placebo plus tranexamic acid really displayed a very, very low rate of transfusion. So we are waiting for the publication with the preliminary results were presented at the last NATO meeting and are quite promising. So if you want to go a little bit further on the problems and question about IV iron treatment, I recommended these two publications. One is the current misconceptions and the diagnosis of iron deficiency. And the other one is the prevention and management of acute reaction to intravenous iron in the surgical patient. So I must say that most of the reactions that we see are infusion reactions that are cell limited. They don't need treatment, just to stop the infusion, wait for a few minutes, and restart to a much lower rate. We have seen that IV iron will provide a safe and rapid and effective way to treat iron deficiency in surgical patients, even when we have a short time. But sometimes it's difficult to organize that the patient receive IV iron. So there are growing interest in newer iron formulation. One of these newer iron formulations is sucrosomal iron. That is a compound that is consists of a core of iron pyrophosphate, which is enclosed in a phospholipid matrix, and it's enveloped in a sequester matrix. The sequester is an absorption enhancer. Well, this is nanoparticulate a compound with a diameter of approximately 200 nanometer that is taken up by transcellular and endocytosis erodes. The endocytosis is mediated by the M cells. The M cells are a special cell that is close to the Peyer's patch in the intestine, and they are all along the whole intestine. So that means that the uptake of iron is not restricted to the duodenum and the jejunum, but it can occur along the whole gastrointestinal tract. And these mechanisms make that over 90% of the absorption is hepcidin independent, and then it's not affected by inflammation. Other particular thing is that the nanoparticles are taken up to the mostly to the lymphatic circulation. Then they will reach the blood circulation, will be taken up by the macrophages and the mantle, and the iron will be available for biological function. There are many studies using this compound in many different clinical settings, and there are a few studies performed in the surgical area. This is one, a recent one, where the author checked the benefits of preoperative oral iron supplementation with sucrosomal iron in cardiac surgery, and they are analyzed the data according to baseline hemoglobin and gender. There were around 600 patients undergoing cardiac surgery. The patients were divided into two groups, receiving either oral sucrosomal iron 60 milligrams per day for 30 days prior to surgery, or standard care. And what they saw is that hemoglobin, preoperative hemoglobin or missing hemoglobin increased respect to baseline, especially in those with hemoglobin below 13, and with no difference between men and women. This increase in hemoglobin translates into a reduction in transfusion rate that was more pronounced in women, but still women have, even when treated, have a higher transfusion rate than men. And also this translated into a lower transfusion index. Less transfused patients receive less units when they were treated with sucrosomal iron. Again, you can see that women were more benefit, but still they have a higher transfusion rate than men. So it's seen that the group of patients that benefit the most from this therapy are those with hemoglobin below 13, and they also are planning now to combine this sucrosomal iron treatment with EPO. So probably what they do is just to select the population with hemoglobin below 30 and treat it with sucrosomal iron at 60 milligrams per day plus 1 or 2 doses of EPO in the preoperative period. Another point is that this center is a high volume center, so this the trial was complete in 2 years. So I hope that we can have the data for the new trial in a short time. Postoperative anemia is also important. It can affect up to 80-90% of patients, and most of the clinicians don't pay too much attention. We have seen for the previous lecture that the trial just focus on to use a restrictive or liberal transfusion protocol, but they forget about to treat anemia. So, and that's why the same group done before, we develop an international consensus on how to manage a postoperative anemia while the patient is in the hospital. So for in a privately, we consider that when the patient have iron deficiency after the surgery or have a hemoglobin below 10 grams per deciliter, you must consider the use of IV iron. If the patient have a severe anemia, even if it's not symptomatic, you have to consider IV iron supplement, and probably also the EPO supplementation, especially in those patients that decline to use to receive a transfusion. In symptomatic severe anemia, we consider we recommend to consider transfusion, the minimum amount possible. We know that most of the time, 1 unit is enough. And don't forget that after transfusion, the patient is still anemic. That's important. And then we have to treat it. There is several studies that showing that this therapy can be effective in reducing the transfusion rate and increasing hemoglobin. And because of the good result obtained with sucrosomal iron in administered preoperatively in cardiac surgery, they try to do it also after cardiac surgery. So this is a respective study of approximately 100 patients in 2 groups. One group received sucrosomal iron 120 milligrams per day for 10 days, and followed by 30 milligrams per day for another 10 days. Patients were recruited for the study approximately 10 days after surgery. And the other half of the patient received 1 gram of ferric maltose after recruitment. And let's say that 1 month after surgery, you can see that, well, both treatments were effective. Hemoglobin level was slightly higher in the ferric maltose group. At the same, we will see for transfusion for transferrin saturation. And as expected, ferritin level will be much higher in the IV iron group. What this indicated is that oral sucrosomal iron could be effective in recovering from postoperative anemia, and perhaps we can either to increase the dose, not only 120 milligrams per day for 10 days, but we can extend this dose, or we can extend the time for treating the patient. So after a take-home message, I would say that please screen the presence of anemia as early as possible. If the patient have hemoglobin below 13 grams per deciliter, all the lab tests needed to classify the anemia and treat them. Many times we need to search for the cause of anemia, and don't forget that some patients can have a combined causes of anemia. It not need to be always ID, but it could be ID in combination with vitamin B12 or folate acid deficiency. According to the data from the lab, we have to tailor the treatment for the patient. The target should be an hemoglobin above 13. We have to consider the time we have to prepare the patient and how we are going to give the iron. We have the vitamin B12, folic acid, whether we need ESA or not. We have to consider if other treatments are necessary to facilitate the anemia treatment. And anytime that we treat an anemia that is severe or moderate, and especially if we stimulate the bone marrow with ESAs, we recommend to supplement also with folic acid and vitamin B12, because these are very cheap medicines with no side effects and can really improve the result when we treat the patient with IV iron and ESA. Don't forget the follow-up. We have to reevaluate the patient early before surgery with the idea to refine or the treatment or retreat the patient if necessary, and then after surgery we have to make an individual plan to follow up the patient, and don't forget to treat postoperative anemia. Thank you very much for your kind attention.